Equipment Lesson 13 covers recorded detail and geometric factors. Recorded detail is the sharpness with which anatomy is recorded in the final image, and it is determined by choices you make before you press the exposure button. We cover the definition of spatial resolution, geometric unsharpness and its formula, focal spot size selection, motion unsharpness types and control, receptor unsharpness in digital systems, and worked calculation examples. 13 minutes. 4 foundational concepts. Spatial resolution, the ability to image separate small structures as distinct and separate. Measured in line pairs per millimeter. Higher line pairs per millimeter means better resolution, a sharper image. Film screen systems resolve up to 15 line pairs per millimeter. Digital flat panel detectors typically resolve 2.5 to 5 line pairs per millimeter. Digital trades lower spatial resolution for much superior contrast resolution and wider dynamic range. Blur, or unsharpness. 3 sources. Geometric blur, also called penumbra, comes from focal spot size and geometry. Receptor blur comes from detector element size and scintillator thickness. Motion blur comes from patient or equipment movement during the exposure. All 3 sources add together in the final image. Total unsharpness is the sum of all 3. Modulation transfer function, MTF, a mathematical measure of how well the imaging system transfers detail from the object to the image. MTF of 1.0 is perfect. No information lost. MTF decreases at higher spatial frequencies, fine detail is progressively degraded. Higher MTF at high frequencies, the geometric unsharpness formula, also called UG, is UG equals OID divided by SOD, times focal spot size. Where OID is object to image distance, SOD is source to object distance, and focal spot size is in millimeters. 3 factors control UG, and the direction of each. Focal spot size, larger focal spot equals more penumbra equals more blur. This is the primary geometric factor. Minimize it by using the smallest focal spot the heat load allows. OID, larger OID equals more penumbra. Minimize OID, keep anatomy as close to the image receptor as possible. And SOD, or equivalently, SID, longer SID means larger SOD, which reduces UG. Maximize SID to minimize geometric blur. The combined rule, maximize SID plus minimize OID. Plus use small focal spot equals best possible recorded detail. All 3 work toward the same goal. The bar chart on this slide shows resolution in line pairs per millimeter and heat capacity at 5 focal spot sizes. From 0.1 to 2.0 millimeters. The trade-off is clear and the registry tests it directly. Small focal spot, 0.1 to 0.6 millimeters, high resolution. Low heat capacity. Use for extremity radiography, magnification. Radiography, where small focal spot is mandatory, mammography. And fine detail skull work. The small focal spot cannot sustain high MA levels, heat damage results. Match the focal spot to both the resolution requirement and the heat load. Large focal spot, 0.6 to 2.0 millimeters, lower resolution. High heat capacity. Use for abdomen, thorax, spine, fluoroscopy, and any high MAS. Technique where the heat load exceeds the small focal spots. Capacity. One exam-specific rule to memorize, magnification radiography. Increases OID intentionally, which worsens penumbra proportionally. Small focal spot is mandatory in magnification radiography to keep UG at a diagnostically acceptable level. Without it, blur from a large focal spot cancels the benefit of the magnification entirely. Two types of patient motion, and each has a different control strategy. Voluntary motion, the patient moves intentionally or because they cannot cooperate. Children, confused patients. Patients in pain or anxiety. Control, patient communication. Positioning assistance, immobilization devices, pigostat. For pediatric chest, Velcro straps, sandbags. And short. Exposure time. Involuntary motion, physiologic motion the patient cannot stop. Cardiac pulsation. Respiratory movement. Peristalsis. In the bowel. These are always present, you cannot eliminate them through positioning alone. Control, exposure. Time must be short enough to freeze the motion. For cardiac motion specifically, exposure time should be 20 milliseconds or less, 0.02 seconds, to freeze cardiac motion for chest radiography. For respiratory motion, instruct breath hold. Use the correct phase, typically full inspiration for chest. If the patient cannot hold a breath, catch the image at the natural pause between breaths. Use high MA and short time, not low MA and long time. Same MAS, far less motion blur with high MA and short time combination. Digital detector unsharpness is determined by detector element, DEL. 3 examples from the bar chart on this slide. Example 1, 0.6 mm focal spot, 40-inch SID. 2-inch OID, SOD equals 38 inches. UG equals 2 divided by 38, times 0.6. Equals 0.032 millimeters. Very small. Blur, excellent recorded detail for routine radiography. Example 2, 1.0 mm focal spot, 40-inch SID. 6-inch OID, SOD equals 34 inches. UG equals 6 divided by 34, times 1.0. Equals 0.18 millimeters. Moderate blur. Visible degradation of fine detail. Example 3, magnification radiography requirement, OID. Equals 20 inches, SID equals 40 inches. With a 1.0 millimeter large focal spot, SOD equals 20. UG equals 20 divided by 20, times 1.0. Equals 1.0 millimeter. Severe. Blur, completely unacceptable. With a 0.1 mm small focal spot, UG equals 20. Divided by 20, times 0.1. Equals 0.1 millimeters. Clinically acceptable. This is exactly why magnification radiography mandates small. 3 recorded detail questions. 1 requires calculation. The answer is B, switching from large to small focal spot. Focal spot size is the primary geometric factor controlling recorded detail. Switching directly reduces geometric unsharpness, penumbra across the entire image. For a hand radiograph where fine bone detail matters, the thin anatomy allows the small focal spot to handle the heat load comfortably. Increasing SID also helps but has less immediate impact than focal spot selection. KVP and MAS changes do not affect geometric sharpness. The answer is B, use a higher MA station for shorter exposure time. Motion blur is controlled by minimizing exposure time. Higher MA delivers the same MAS in less time, freezing respiratory motion. For a patient who cannot suspend respiration, catching the exposure at the natural pause between breaths and using the shortest possible time with highest available MA is the correct approach. Changing KVP or SID does not reduce motion blur. The answer is B, approximately 0.11 mm. Formula: UG equals OID divided by SOD, times focal spot size. SOD equals 40-4 equals 36 inches. UG equals 4. Divided by 36, times 1.0 equals 0.111 mm. Clinically acceptable for most routine work, but not for fine detail imaging. Switching to a 0.3 mm focal spot under the same conditions would give UG of 4 divided by 36, times 0.3 equals 0.033 mm, dramatically sharper. You covered recorded detail including spatial resolution and MTF, the geometric unsharpness formula with its 3 controlling factors, the focal spot resolution versus heat capacity chart, voluntary versus involuntary motion and exposure time control, receptor unsharpness in digital and direct DR systems, and 3 worked UG calculation examples. Know the formula and be ready to apply it on the registry.